Good morning and thank you. So the Eastern Africa Harm Reduction Conference brings together countries from the eastern part of Africa that are engaged and have embraced harm reduction amongst key population within our communities. So we come together to showcase innovations, progress towards harm reduction strategies that have been recommended and embraced by the WHO and other partners like UNAIDS and UNODC, together with the governments of the respective countries.
Okay. All right, let's hear from Onesmus as well. Good morning.
Good morning, Debarl.
Why this conference? Why now?
Yes, as you stated in your opening remarks, the drug challenge is not a one-country challenge.
Yes.
And especially in the Eastern African region. In the recent past, the overflow of drugs, especially hard drugs in this region, has actually been on the increase. And this has been evidenced by the increasing seizures of hard drugs like heroin. What this means is this could be quite a lot more that is actually getting either into our region without being seized. And for this reason, we have actually seen an increase in the number of people who are actually using hard drugs, heroin, cocaine. And many people have actually been addicted to this. And because of this, we have actually brought together people from the Eastern African region, not only just to start on progress made, but actually innovative ways on how actually we can be able to deal with the issue of drugs, bring back people who have actually been addicted to drugs, mostly forgotten actually, to actually being again citizens who can be productive.
All right, let's say from Rita as well. I know maybe it has been a harrowing torture for you once you got involved with this drug abuse, and coming out of it is really like breaking away from that barnacle, that tentacle that is so hard to come out from. Maybe you can just give us a very terse, a note on what really you went through, and of course we'll be highlighting this in the course of the program as well.
Okay, well, thank you very much, and thank you for having us. As they've mentioned, harm reduction is very important. It's actually the most important tool in the war on drugs. And the reason for such a conference, apart from showcasing innovations, is to show the world that this thing works, that harm reduction works, that you can have been addicted to drugs and you can be saved, you can come out, you can go back and be a productive member of society. As you said, it's been a harrowing experience. I think that's the best word. But it's been a learning experience as well, a learning experience like no other. What I can say I've learned is that we need an overhaul of how we educate ourselves on issues as Africans. We need to look at how we deal with everything afresh. So I think we'll be going into that a bit more, but it's been an experience and it's really an honor to be here, and I'm here because of the harm reduction program.
Thank you very much. Twalid Wamala, I think I didn't introduce you, but of course I take this opportunity to do that from East African Harm Reduction Network, who they have been also heavily involved in organizing this conference. Good morning to you, and tell us more about this particular conference. It's ending today. Why do you think this was a providential time to actually highlight the harm reduction?
Good morning, viewers. The war on drugs has been a very terrible problem among the East African countries, and it is a situation that where most government have been neglecting this issue, and has been a very big problem. Where we have been losing our brothers, sisters on drugs, and the government could not accept that this problem is existing among the East African communities. So it happened as East African communities that we decided to come together and formed the East African Harm Reduction, an umbrella organization that coordinates 8 countries and makes sure that the issues of harm reductions are being included in national strategic plan among those 8 countries. That's Uganda, Kenya, Tanzania, Burundi, Mauritius, and Seychelles, including Kenya as well. So this meeting is very important, that we are bringing people from all over Africa and Europe to come and share the experiences of how harm reduction works and how can we work together to solve these issues that is killing our brothers and sisters that has been neglected by the most government countries. We have done some research, and the evidence is there in most of these countries,
yes,
that the percentage of people who are using drugs is 20 plus,
yes,
among the general key population. So people who use drugs have been key drivers of HIV, and this is a group of people that has been neglected.
Thank you. All right. We'll turn our focus now this morning on the topic of the day, where we are looking at the East African Conference. East African has continued to become a significant region in drug trade. While initially it has been more of a transition route, there has been increasing demand of drugs for consumption. Africa is estimated to have received about 9% of the global flow of heroin as at 2011, according to USAID 2013. Increase in drug consumption in the region has come along with new challenges to public health and security. With the region already experiencing a HIV epidemic, increasing drug use has exacerbated infections, especially among populations of people who inject drugs, and also highlighted other blood-borne infections such as viral hepatitis, especially hepatitis C. Most of the healthcare systems have been addressing drug-related problems in ways that have left significant gaps in addressing other challenges that come with drug addiction. Supply suppression and demand reduction have remained the key strategies being enforced to manage drug trade and consumption. Consequently, these two approaches have traditionally missed opportunities to address concerns among drug users, complicating health and social outcomes. Harm reduction is an approach to the drug use problem that has recently been introduced in some countries in Eastern Africa. Harm reduction works to reduce the health, social and economic consequences of drug use while considering the health and human rights of people who use drugs. Mauritius, Kenya and Tanzania have taken bold steps to initiate strategies and interventions fronted by the harm reduction approach as effective in mitigating drug use problems. In these three countries, needle and syringe programs and medically assisted treatment in the form of methadone have been introduced, primarily targeting to reduce HIV infections among people who inject drugs. So this morning we turn our focus on that here on Standing on Guard. We take a break from, of course, the normal security analysis with our experts and train on this also because there's a big niggling worry also for the Eastern Africa or the Eastern African countries right now. We know this conference, which started on the 26th, also is being summed up today, I should say. And I want just to introduce our guest who we did at the top of the hour, introduce them as well. But if you're joining us, I can also allow you to see their faces and hear their voices this morning. We are holding court this morning with Dr. Jebet Boit. She is the Assistant Director of Medical Services, Mathare National Teaching and Referral Hospital. Also, we do have with us Onesmus Mulewa, who is a Program Director from Kanko. We'll give you more details of him as well. Also, we have Twalid Wamala from the East African Harm Reduction Network. And we do have with us as well Rita Nyaguthii. She is a recovering drug user. All right, thank you very much. Let's just continue with this conversation. Of course, we gave a highlight from the beginning when we started the program, but we want to begin with you, Onesmus, to tell us more about this particular conference. It began on the 26th, running under the theme, you will tell us this morning, I think is innovation in trying to tackle, of course, harm reduction. Could you tell us more about this?
Thank you, Debarl. The theme is actually leadership in harm reduction.
Leadership in harm reduction.
Yes,
thank you.
And why we dubbed that this conference with that catchy title is because the issues of drugs actually require pragmatic leadership.
Yes.
We really have to make any significant progress. And for many probably will be wondering what harm reduction is
yes.
really all about. And harm reduction in a nutshell relates to policies, programs, and interventions that are actually aimed at reducing the harms of people who actually use drugs. Now, if you look at that three approach of policies, programs, and the interventions, it means that it's kind of like a whole basket that brings together a totality of approaches
yes.
that will actually reduce the harms associated with drug use, and more so for people who inject drugs who we know are actually at the height of blood-borne infections, including HIV and AIDS.
Yes.
If you look at the statistics, people who inject drugs actually have more than 2-3 times the prevalence rate compared to the general public. So this actually requires a lot of goodwill and leadership for people who are actually going to look at what are the best policies that we need to have in place to ensure that people who actually use drugs receive essential services. What are the innovative interventions that we need to put in place? Because people who use drugs will require a total different type of interventions. Because these are people who are addicted, and with an addiction, they will do anything to do a drug.
Yes.
And of course, we're looking at whatever programs exist and a multi-sectoral approach that will actually be able to ensure that everybody pulls, and we have a kind of a concerted effort to deal with this issue. So this conference actually brings all actors, both government, civil society, practitioners, the academicians, to share what are the best models of leadership that have actually been applied in countries that have made progress in harm reduction, where actually drug use has not meant a death sentence, but actually people have been able to live a productive life and actually be able to do meaningful work within their own communities. So it brings all this multi-sectoral, it's an opportunity for people to actually share, show the models that work, show the innovations that work, and again, show kind of the future of what actually we need to do in the region if we need to make progress in harm reduction. So there's quite a lot of rich mixture or combination of people at this conference that's happening. That includes governments that have been progressive in showing how they have actually been able to make progress in harm reduction, so that we can actually be able to see, because some other countries within the region are still not able to move through the stage of moving away from drugs and the drug suppression and criminalization to actually active bringing people who use drugs to actually inactive service delivery. So this is the whole nutshell that's happening within this conference this week, which is ending today, and today is going to be quite an intense day.
Okay.
We have several parallel sessions running. There are sessions that are dealing with treatment, that we have treatment models, sessions that are dealing with capacity strengthening of institutions that provide services, showing how they have actually been able to do that in a much more innovative way. And there are also sessions that are dealing with real experiences from people who have actually moved from drug use and sharing the experience on how it is actually to be a drug user and the challenges that they go through.
Right.
So this is what's happening.
Thank you. Let's say from Mr. Wamala from Uganda, and of course you've been working with in liaison with Kanko, that is a Kenya NGOs, Kenya AIDS NGOs Consortium, and you're telling us, yes, East African Harm Reduction Network also has its own approaches on how they can actually do the harm reduction, and you have been liaising with the Kanko. Can you tell us what has been the approach so far? Why are you coming together for this particular conference, and what are you aiming to achieve?
Yeah, thank you very much. It's true we have been working with Kanko for some time now, and the problem of drug is not for one country. It's a global war on drug, and when you look at most of these countries are neighboring, and there is drug trafficking across all these countries: Uganda, Kenya, Burundi, Seychelles, and Mauritius as well. So when you look at the events of the drug that is consuming our brothers and sisters, and most of the countries have been keeping quiet to this problem, they are not bothered, they don't want even to speak that there is a problem within the countries. So having realized that things were not going right, and the people were dying, and our governments were keeping quiet, the question was, if you are telling us that these people exist, where are they? How many are they? And tell us where we can find them. So the government positioned themselves in having an approach which is using criminalization approach, where they are looking at the victims of drug use as people who are to be arrested and put in prisons. So, and people are not bothered, they just looked at them as people who are thieves, people who are robbers, people who have no hope. So involving in those kind of circumstances, and most of the governments looking at these communities as people who are not there. So we formed up with Kanko to come up with an idea that we can have a network that can mobilize, and having these groups come together and fight for themselves, having a voice that the government will have. So having one voice from one country was not making sense to change the laws within the East African communities. But the formation of East African Harm Reduction brought 8 countries on board. Having 8 voices from different countries, that is a huge support. So of now, the network was formed. It is looking in providing issues of providing data within the country, of which now I'm glad to inform the viewers that we have data from all 8 countries that we are using now to tell the policymakers that this is a problem within your country. You need to come up and support these people. They are not criminals. They are people who are sick, who need medical interventions. So governments are coming up and supportive. So we are looking at the policies. What are these policies within the region? What are these policies saying? And we have realized that we have all, in 8 countries, we have the Anti-Narcotic Law, the Penal Code Act. All these laws criminalizes the users. Even those who are being in possession of drugs, they are also being arrested. So now, looking at these policies coming up, you find that these policies are not reflecting the public policy approach. They are just looking at the way of picking these people from the public and dump them in prisons. So realizing that all these laws are the same, now we had to bring on board the law enforcement. The policymakers are getting involved, and now after realizing, understanding the approach of harm reduction, now they are supporting our call.
All right, thank you very much. And of course, we criminalize these people. If we may just also rope you in, Dr. Boit, to tell us more about, psychoactive drugs and the way we've been treating people as criminals, yet it is a medical condition. How then do we try and put that demarcation line that, yes, these are the people who are under the influence of psychoactive drugs, and they shouldn't be taken to jails, they should be taken to hospitals. And I know you've been dealing with a lot of this, people also who are teetering on the, on the borders of, going bashi bazooka, as they say, they're losing the cognitive processes as well. Just rope us in on this a bit.
Thank you, Debarl. With mental illness, as you rightfully said,
yes,
we have, patients who are addicted to psychoactive drugs,
yes,
and that changes their behavior. And part of the behavior change is what is recognized by the law as, criminal activities. And we have been able to incorporate what the Kenyan Constitution actually recommends about human rights. You have a right to receiving health, medical attention.
Yes.
So what the Kenyan government has done through the Ministry of Health is, address what the Constitution says about providing health care to this, anyone who has mental illness or illness in general. So once we bring in these clients and you realize that they have drug addiction, but at the end of the day, we know that it is a mental illness. So we provide services for these clients, but also work together with the lawmakers, as my colleague has said, decriminalizing what we call petty crimes, and also linking them to medical facilities.
Yes.
So that they're given rehabilitation services. Because we know these clients sometimes are labeled as repeat offenders.
Yes.
One case in particular when we're working with the police is that these clients, you keep on arresting them for the same crimes. Stealing here and there, muggings here and there. But once we enroll them into these programs, and particularly for us,
yes,
when we look at harm reduction, there are several components. We have 9 key components of harm reduction. And we are proud as a Kenyan government or Ministry of Health to say that we've been able to actually implement all 9 of them. And the 2 main ones that I'll mention is medically assisted therapy or opioid substitution therapy, where we use methadone, which is able to prevent, craving and, put down withdrawals for clients who are addicted on heroin. So once they put on methadone, they no longer have to, be engaged in drug-seeking behavior, which is criminal. So that helps bring down crime rates. The second activity is needle and syringe exchange, which actually our partners at Kanko were able to start really early, around early 2000.
Yes.
Where now we look at harm reduction because needle sharing practices are reduced, and that is where a lot of spread of bloodborne viruses was actually coming through. So I must say that we've been able to partner with the policy makers. We have the police, we have the judicial system, where we've been able to work together in a forum where we have agreement on how we can be able to offer services to our clients and not actually criminalize them, but actually realize that this is an illness, provide the service, and also rehabilitate them. But also we have to respect the country's rule of law.
Thank you.
During that process.
Thank you, thank you. All right, let's see from Rita. Of course, you were just emerging from the harrowing tortures, as we said, of drug abuse, recovering a drug user. Just give us an experience. Were you involved? How were you involved in this psychoactive drugs, and what sort of a psychoactive drug was this, and what has been the journey for you to recovery?
Thank you, Debarl. Now, when I was in my 4th year of campus, with the ordinary pressures of campus, I would try a few things, as many campus students would. Now, the thing that we didn't know, the thing that our education system had not got, the level we hadn't gotten to, was being able to differentiate which drug is which, what will happen to you if you try this, what will happen to you if you try this. So I tried the now usual things that people try in campus. I tried marijuana, cigarettes, but the day I tried heroin, that's the day that, with heroin,
yes,
the first time you try is all it takes. It's all it takes for you to now begin the process.
Just
of
the first jab?
First, doesn't even need to be a jab, because I never jabbed, I sniffed.
You sniffed?
Yes. So the first time, that's it. So as long as your brain now knows that there's this thing that is very sweet initially.
So just a sniff and you're hooked?
You just sniff and you want it again. At first you want it, you want it, you want it. After about 2 weeks, you need it. Because if you don't have it, the withdrawals that come with heroin are completely, they're physiological in every way.
Yes.
They affect everything. They affect from your brain to your toes, everything. So you will need it. I tried to stop, but one thing I've realized with these hard drugs is no amount of wishing, no amount of education, no amount of proper upbringing will give you the strength that you need to be able to get out of this this addiction. So I continued using while attempting to balance that in school, which becomes impossible. You can't work because it's either you can't sit at your desk as you do. You can't sit there and read the news because your body is you're sick. You need something, so you will either go to work or go to the den. So you will find yourself at the den, and at the den you'll meet people who are using, people like you, and you'll feel a sense of community because this is something that you cannot reveal to your people. You can't dare reveal that you're using drugs, or that's the stigma that's there. Even just myself, for me to be here is for me to have fought so much stigma so that somebody else can hear it. So I used for a while. I used for about 3 years, juggling school. I was unable to finish at that time. Luckily for me, in 2014, the methadone program, as Dr. Boit has said, Dr. Boit was actually my doctor at the clinic. The methadone program was introduced. I didn't need I didn't benefit from the needle exchange program because I wasn't an injecting drug user, but it was equally important for that methadone program to have come, because without it, I am 100% sure I would either be in committee or in the grave. There's usually no, there's usually about 3 options: prison, hospital, or the grave. Those are the 3 options that we had before the harm reduction program came. So that's been my experience. I've met people from all social classes. I've met children of ministers as well as orphans in the same setting, all having the same problems. The same problem now. As we are using, we are having the same problem, but we're coming from different social backgrounds, different problems that have led us to that place. So it's really it's a very diverse environment. People coming from different places, and that's why this harm reduction conference is very important, because were it not for such interventions, very many of us would have would have perished when we are actually very productive members of society. People don't steal because they want to. Actually, drug users are not thieves by nature. They're not thieves by nature. But you get to a point where you run out of money, because today you might use 200 shillings. Tomorrow you need 400 shillings. Your body needs more. So by the time you get to a point of needing 2,000 shillings a day and you don't have a job, you'll have to get that money somewhere. And it isn't really your wish, but your body needs it.
All right, Dr. Boit, just tell us, because of hearing experience, just as one sniff, just a sniff of it, and you find it changes. I don't know if it's a circadian rhythm of your body, and you know, your cognitive processes changes. What really happens with just one particular sniff of, let's say, heroin? From the medical point of view, I'm surprised that it's just a sniff, then you're hooked.
There is actually different responses. To these drugs of addiction. For her, she reports that from the first sniff, she was able to, she had this desire, repeated desire to take more and more. Different clients have different responses to these substances of addiction. But one thing we know is that heroin in particular, you can either sniff it, smoke it like a cigarette, inject it. But all in all, substances of addiction, just like alcohol, you start with just a little amount, and then your brain remembers because of what it triggers. You feel calm. We call it generally euphoria, or what our clients call steam. There's this general feeling of wellness, and you know, your brain remembers that. So from one client to another, you might need it the next day or the same day, but generally it's what we call tolerance. Today you start with one sniff, tomorrow you go to the same setting, like for her in campus, you know, today you guys meet up and you have a fix, tomorrow you meet up and have a fix. So that repetitive exposure causes repeated memory. There's memory that is kept of those experiences. You develop tolerance. That means if I needed one puff of heroin tomorrow to feel the same euphoria, I'll need 2 puffs. On the third exposure, I'll need 3 puffs to feel the same effect. So you're building your tolerance, and that is the foundation of addiction. Whatever dose you started with is not what you're taking in right now. And you'll realize even there's that transition of the way you use it. You'll start with puffing or sniffing, but generally as your tolerance increases, you have to inject in order to feel the same high. Same thing with alcohol addiction. You started with 1 glass, but in order to experience the same high, you know, you're taking a whole bottle. So that's just the basis of addiction. And also, you know, with the field of mental health, you talk about what started first. Did you have a mental illness? Did you have a psychological issue that took you to drug addiction? You needed to numb some things? Or did you have drug addiction, and in the process of getting addicted, you also develop certain psychological issues or mental illness? So both of them go hand in hand. That's why it was recognized as a medical illness and justifiably requires medical attention. But that basically is the pattern of drug addiction. Now, once the client has reached a stage where they're addicted, and now it's not a matter of over the weekend, I'm going to meet up with my friends and we're going to do heroin. Now your body demands. You wake up in the morning, you want to go to school, you want to go to work, but your body is actually craving it. You don't want it, you're fighting it. So there's that pattern of, there are those symptoms that the client comes with, which are very, very painful and hard to manage.
All right, let's say from Onesmus, because I think also we are looking at the tail end of dealing with the symptoms and the problem itself. But can we look at the entire supply chain of these drugs as well? Because this is a trafficking end round, and I think Kenya also is a major hub of having this particular, you know, psychoactive drugs being, you know, transmitted to other countries via Nairobi, especially also Mombasa as well as a major hub. You can tell us from your own experience, assessment and research, where we are at dealing with this particular transitional mode or hub.
Well, Debarl, I think the challenge is probably much bigger than many of us would probably know. I know the governments and the security arms probably know this much better. But from just the little research we've done on how drugs actually move, it's quite cunning and extremely secretive. If you look at our borders, for instance, I mean, we hardly can afford to, we can't afford to have a policeman at every one single step along the expansive coast. And I'll tell you, there are very many crafty ways of how drugs move, for instance. How many times would probably a policeman dive under a fishing boat and see what is stuck under the boat? You will probably jump into the boat and see what is in there, and you'll find a couple of few fish. And that's how drugs move around. I can tell you, we did some small research. At what time, for instance, would you be able to unveil a Muslim woman? You can't. And I'm not saying Muslim women are traffickers, but drug traffickers will disguise themselves as Muslim women. So if a person who is dressed like a Muslim woman puts drugs under their veil, at what time would you even dare touch that veil? You couldn't do that. So people know some of these cultural dynamics that would actually help them move drugs around. At what time or how many instances, unless there is a tip, would a policeman stop a young schoolboy carrying a rucksack passing through a police station going to school? Most of the time, they will even aid them pass through a traffic line. But these are the cunning ways drug traffickers or the peddlers have found where drugs actually move very quickly. And if today you gave a small boy a rucksack and told them, as you're going to school, when you reach this particular point, just drop this, and you give them some 10 shillings or 20 shillings to eat mandazi in the afternoon, they'll feel extremely happy. These are the very many cunning ways that drugs move out very quickly. And sadly, these ways are actually introducing drug use to young people less than 18 years, less than 10 years, quite at an early age. Because children are curious. What is this that I'm carrying every other time, and I'm given some small monies which is coming quickly? And soon they get hooked. And then we are getting into much a deeper problem. Today, dealing with a minor who has a problem has all its complications, informed consent and all that kind of stuff. And there are quite a number of minors today who are actually involved in drugs. So the chain, when we think about the drug trafficking, most of the time we'll be thinking about our Jomo Kenyatta International Airport or Mombasa Port. Yes, this is happening, and we have seen the seizures that have happened in these ports. But those are the big boys. But look at what's happening at and that's where the real challenge is. A lot of unmanned fishing ports, a lot of open borders. Today we just don't know how much is moving from Somalia to Kenya. And it's really a huge challenge, Debarl. A lot. You go to Ethiopia, you hear the same story. You go to Seychelles, we are dealing with Seychelles, you hear the same story. We have programs in Burundi, you hear the same story. Because you go there, they'll tell you Tanganyika is open. Drugs are coming from Zaire through the ports in Tanganyika. You can't stop them.
You can't stop them.
And then when you get much deeper, we have interacted with the law enforcement agency. There's quite a lot of cartel and rings that traverse the social spectrum. From community members to the justice system. It's a whole complicated web. So I think this is a real challenge and problem that we need to pragmatically start thinking about how we actually deal with it.
Right.
Because it's quite huge.
Right. And we actually drawn into that particular tangled web. Tawid, if I may just rope you in as well and ask you, your president was actually recently here with our president, and they were actually, mulling over this open border posts, right? What does that really portend? Hearing what Onesmus is telling us, the transitions and the way it's a very intricate way of transmitting this particular vices or drugs, the psychoactive drugs as well. Do you think if we have open borders as well, also that will exacerbate, the use of this particular drugs and the transmissions? Or
thank you. To tackle such a kind of a problem, it needs all the government to first address unemployment, which are within the East African communities. Because when you look at most of these drug users, as my colleague said, are people who are unemployed. Every day universities people are graduating every year, hundreds and hundreds, but there is no job employment. And now these people who are within the drug balloons use these people because they are disparate. For example, we have around 100 Ugandans who are in China in the prisons waiting for their death sentence. These people were used by the drug traffickers, giving them free visa, free air ticket, and whatever. They give them an envelope that you will find someone and you deliver this envelope.
Yes.
And these others manage to deliver them, others are arrested, and others are facing their death sentence in China. So when you look at these kind of programs and you see how our police officers are corrupt, civil aviation people are corrupt, because as I talk in Uganda, there a case which was opened to 7 police officers who picked an exhibit at the airport of heroin, and they ended up selling.
Yes.
Selling, and now these guys are facing the charges of selling the drugs. So you look at the systems, African system are dying every day because of corruption. That a person can be able to walk at the airport since he has the money, and nobody will say, you have the drugs, where are taking it? He's giving money and he passes. Because these people who are dealing in drugs are rich people. So opening the borders has nothing to do with drug trafficking, because even now when the borders are closed, people are moving drugs. So me, what I'm saying is, it is only that the government should be honest, that we have this problem. This problem should be looked at the way how HIV is being looked at. A person who had HIV, by then you couldn't sit with him at the same place. But now, since after awareness program, people getting engaged and understanding the dynamics of HIV, knowing how you can live with HIV, but now you cannot know a person with HIV unless you test. So to me, the government should come up with educative programs, educating the youth that these drugs are dangerous. These drugs can kill. So that a person know that these drugs I'm taking, at the end of the day, they will end up my life. And let there be livelihood program within the countries. People are giving work, not only to dump these people in rehabilitation center. You find this rehabilitation center, there is no activity. Let there be streamlined, responsive rehabilitation centers, where a person works in a rehabilitation center, there are some activities. For example, there are bricklaying, people are trained how to make cakes, people are trained how to dig, that a person after 7 or 6 or 1 year on rehabilitation, a person comes back to the community with the knowledge to be able to start a new life. A person who goes to the prison, to the rehabilitation, is rehabilitated, he comes back, there is nothing like what to eat. The person within 3 months, the person goes back to the drugs. So you see, that kind does not need only civil society. This is the role of the government. Actually, what we are doing the work which is supposed to be done by our governments, and our governments are denying these people. But when it comes to elections, now they begin looking at the drug users as people who have sense. But now they are looking at them as people who are criminals. But also these drug users are people who need support. We have seen presidents who are drug users. They changed, they rehabilitated, and they became responsive citizens.
Yes. All right. Because we have also numbers, and I think the Ministry of Health has done this, that most people who use these particular needles and syringes, the number is appalling, or it's actually staggering. Over 18,000, and most of them also are HIV infected. So what does this portend, especially to security of the youth and using these needles? And you have the program you've given us, the 9 principles, and 2 of them is medical assistant therapy, where you use a method, and of course the other one is needle and syringe program. So we want to know, how do you go about as a country? First of all, you can comment on that particular figure, and also how do you go about in the country distributing? Are you distributing these needles and syringes to these people so that they don't have to share, there is enough in circulation, or what really happens?
Thank you. So I'll talk about the epidemiology, where we have this huge number of people who, we have the whole of them called people who use drugs.
Yeah, but for the sake of my viewer who does not really understand epidemiology, you can actually just break it down so that it doesn't go way over our heads. Yes?
So we're just looking at the numbers.
Yes.
Yeah? Where Kenya was able to map and count how many drug users do we have.
Yes.
And the number is huge, 18,000 injecting drug users. And we have many more who smoke. Yeah, that's why we're saying as a community, it's just people who use drugs, but of more importance is those who inject.
Yes.
Now, the government was able to respond to that key population, or what previously was being called hidden population, where nationally we are happy the prevalence of HIV is coming down. Right now we can say our HIV prevalence rate is 5.6%. But when you look at this key population of drug users, the prevalence of HIV is 3 times, 18%. So the government looked and saw there's a gap here. Why are we reducing the national prevalence? But we have pockets of people whose prevalence is actually coming up. So that is where we have key population program within the Ministry of Health through NASCOP to address that gap. And now, and in order to be able to bring up that policy, we're able to look at the harm reduction package.
Yes.
Where we have our partners, CANCO, we have UNAIDS, UNODC, and one of the things that we're able to start with our partners, CANCO, is needle and syringe exchange program. It was not easy for you know, the country to accept it. I mean, you have drug users. Where are we giving them needles to continue injecting? It's like you're encouraging it. But the basis is this. These clients will share these needles, have very unsafe methods of injecting, and that actually hastens the transmission of HIV. If you're together in a den, as Rita has said, you with your friends or that community, and I'm using my needle, and then once I'm done with it, you give the next person, because they were not really readily available to be able to get a needle and syringe. So if the initial person is, or the first person to inject is HIV infected, that's an immediate grafting of the virus to every other person who's using. So the spread was really rapid, and hence the response by needle and syringe exchange program. We have these kits where you have a clean syringe, sterile needle, syringe, and a swab with some spirit, so that you can clean the area and inject. That was the first response, so that at least you can curb the rising spread of the bloodborne viruses. We have HIV, but also hepatitis C is really prevalent amongst this group. Actually, one of the other pillars of harm reduction is hepatitis C treatment, which as Kenya we are proud, we've also been able to start and scale up hepatitis C treatment. So generally, we do actually have a huge population, and currently I can be able to say that the Ministry of Health is actually doing another census or another mapping, because then, you know, we need to see currently what numbers are we dealing with.
Yes.
So what we do, we work with evidence and present the government with evidence that there's this gap, we need to address it. We're also hoping that through the needle and syringe exchange program, we have reduced the number of possible injectors, and therefore, you know, be able to achieve our goal of reduced HIV harm through spread of needle sharing. And of course, when we meet in such a forum, the Eastern African Harm Reduction, we actually have, you know, the health service providers who are presenting abstracts. People have written scientific papers. In Burundi, this is what we did. It has worked. In Kenya, we have papers. In our programs, this is what we've done. We've talked about NSP, which our partners CANCO actually started way back, until the government was able to negotiate for methadone to come, and we piloted it in Madare on December the 8th, 2014.
Thank you.
Yeah.
Right, thank you. Let's say from Onesmus, because we talk about supply suppression and demand reduction, right? The issue of having this particular exchange programs, needle and syringe, also, you know, it's costly. And we wonder, right now, we're given to understand also there's sort of a donor fatigue, and money has been a big problem. Also issues of corruption, where we have also the Global Fund, which is a huge donor when it comes to fighting HIV and AIDS as well. How have you been, as an organization, been able to sustain yourself to make sure that, yes, your good salutary effort is afloat and also funding is coming through as well with this economic contraction challenges as well.
Thank you, Debarl, for that. Just before I jump into that, I just want to quickly contribute to what she was just talking about, the numbers.
Yes.
The government is doing a new study, and it's possible that we could have more people, so to speak.
More than the 18,000.
Exactly. When we started our initial estimates, we were talking about 3,000 people who inject drugs. Mm-hmm. When the government went ahead and said, can we look a little bit more deeper, the numbers jumped to 18,000. And even so, if you look at the size estimates that were done at that particular time and the areas that they focused on too, there were some other areas that are actually critical coming up with people who inject drugs. So the problem could be bigger. So the numbers, don't be surprised next time you're reporting this on AM Live, could be 30 or so. Wow. But that's the kind of a thing we're actually talking about. So let me quickly come to supply suppression, demand reduction, and harm reduction. Supply suppression, demand reduction, these are the traditional ways that many of the global governments have actually been trying to adopt, because the whole idea is, let's not have supply of hard drugs. I mean, cut it off and forget it. And then, on the other hand, let's have no people who demand for these drugs. So if you don't have demand, and supply will naturally go down, and then you cut this whole story.
Which is unrealistic.
But what has happened is totally unrealistic, and it's not working, and it has not worked anywhere else. So when we looked at countries that have made significant progress in actually dealing with the issues of drugs, talk about Switzerland, talk about the UK, these are countries that, apart from supply suppression and demand reduction, they adopted harm reduction. Because as long as the drug still can be found, how best can we actually deal with this person who still can't find the drug? Should we let someone actually sit in a sitting with 8 other people and share a needle? And as you've been showing those clips there, injecting is a ceremony. It's not a one-time thing the same way you go to a doctor because you have malaria or whatever and you need to get a jab. It's a whole long process of injecting, pulling blood back into the barrel, stepping it again. Someone could take up to 15 minutes actually putting a needle in the blood, and then immediately it moves out, someone else takes it. So this is where the entire transmission of bloodborne viruses actually, diseases take place. So what happens with the introduction of harm reduction is, as governments and law enforcement agents continue with the war on supply suppression and demand reduction, and we hope we succeed one day, that there will be no heroin, no cocaine, whatever it is, that would be good. But as long as still we are having people accessing drugs, let there be another alternative that is going to save someone's life. And when we talk about sustainability, our principle is there's no value to life. You can't value to life. You can't attach a cost to life. So if it has to take this much money,
yes,
let it take this much money. And what's happening is we had actually very progressive support. The idea is the same way. Malaria keeps on killing people, but governments invest in malaria treatment medicine. That means it is available every other single time, and it costs money. The same way, when people who were living with HIV and AIDS came into, and it was all about ARVs, how are we going to sustain ARVs? It's a life treatment. But that changed because you cannot attach a value to life. And now we have treatment that you don't even have to wait until a particular stage. You treat today, you're positive, you're put in treatment.
Yeah.
That's the direction we're going with harm reduction.
Thank you.
That we should invest. If it means that someone has to inject, let that person inject with a clean needle. And I think, I'm hoping, I'm seeing a day that someone who actually injects and actually needs to inject will walk to either a public health hospital and acquire a clean needle that they can actually inject, because that way you're actually reducing a bigger problem.
Thank you. All right, thank you. Let's say from Rita, finally, tell us, are you out of this space completely? And what are you doing as a person who, has recovered from, that particular drug usage? And how are you helping also the young people who are hooked right now and they feel maybe there is no hope? Is there any glimmer of, or a ray of hope at the end of a tunnel?
Okay, thank you. First thing I should say to answer your question is your first question, which is, have I recovered from that situation? I am no longer using drugs. I have successfully completed my time at the methadone program.
And there are no relapses completely that you feel yeah, maybe there's a flaming urge to...
Now that's a good question. I've had to completely rewire the patterns in my brain. I've had to completely, with the help of the doctors and the support, I've had to completely rewire my thinking because, as they've said, when you're using drugs, you actually have a mental issue. So on the issue of relapse, all those are realities. They're there and they are accepted even within the rehabilitation community, and there are things that are being done to address that. There is follow-up. After you're done with the clinic, you do come for follow-up. If you have any pending issue, they train you on how to reintegrate into society. So, and with addiction, as you know, once an addict, always an addict. That's something that we're always told, because as much as you're not using it, your brain still knows that there's something you used to use and something very strong. So you really have to control yourself and be assisted to control yourself and your environment. I can't go walking. I can't go walking to the dens. I can't go for myself. That's me. I know my trigger points. There are places I can't be. There are people I can't be with. So yes, I have recovered, if that's the word that I can use. And what I'm doing is working with the people who helped me recover to reach as many people out there as possible. I am very lucky that before I started using drugs, I had gone through our system of education. There are very many people who were not lucky enough to even know what heroin was, to have an opportunity to get a job after having used. And those are some of the issues that we're trying to address. So for myself, being in a position of, to be able to sit on the fence, to have seen the urban side of it, and to have seen the downtown side of it, puts me in a very unique position. And I can't do anything other than use that position to help them reach as many more people as possible and spread as much awareness as possible that these things are here. They don't care who you are, and they are coming. There's an opioid crisis in the US. And as we know, anything that happens there, anything that happens abroad will always end up here. So we really need to be prepared, very prepared. And again, the effects of capitalism are being felt everywhere. Joblessness, despair. So more people will sell drugs, more people will use drugs. So as a country and as a region, as East Africa, as Africa, we really do need to be prepared and speak with one voice. So that is where I am placing myself.
Thank you. Of course, even maybe as your headline thoughts, and people were watching this morning and perhaps they're hooked and they're wondering, yes, how do I get out of this, morass? Been hooked, and you say once a drug addict, always a drug addict. And what will be your final message to them this morning?
My final message to anybody who is currently suffering with drug addiction: don't suffer alone. Don't suffer in silence. One, you are not alone. There are very many people who are going through that, and there are centers that can help you. Bring yourself to, or have someone bring you to either Madare Hospital. There's Medicine du Monde. There is SAPTA. There is actually reach out to any of these organizations, and you will definitely get the assistance that you need, because at this point, as Kenyans, we should be very proud of ourselves. There are countries like Burundi that are still fighting even needle exchange programs. So we are very, as a forward-thinking nation, nobody should suffer alone.
Thank you.
If you have that problem, just come forward. You don't have to do it openly. Just come in secret, and you'll be assisted.
All right. Yeah. Okay. We have 30 seconds for you as well, Twalid Wamala, to just give us your headline thoughts as well. Moving forward, do you see this fight being successful? How do we sustain it? Very briefly. 30 seconds, sir.
Yeah, I may say we have not reached where we want to be, and we are still on fight to see that all the countries embraces the harm reduction intervention, 9 programs, as my colleague has said. So what I'm calling is the government to invest in harm reduction. It has been scientifically approved that harm reduction saves life. Let all the countries embrace. They shouldn't look at the drug users as victims, and they should change the way how these police officers are arresting these people, beating them, but they should arrest them if they are to arrest, but linking them to their services. So that's my message.
Thank you.
And I feel like in my country where I'm coming from, Uganda, that they should also embrace methadone treatment as our neighbor Kenya. They are far ahead than where Uganda, we don't have these services.
Thank you.
Yeah.
Thank you. Let's hear from Dr. Boit. Your 30 seconds, of course, begins now. And you tell us what is the high spot also of the conference, and what are you aiming to achieve, or what are you learning? Very briefly.
The highlight of the conference is innovation in harm reduction, where we've been able to showcase strategies that work from the various countries, and learning and sharing information amongst the Eastern African countries that have been able to participate in this conference. Another highlight is the goodwill from the government of Kenya, where we had our cabinet secretary, who was just 22 days old in the ministry, coming to open the conference and actually give a support towards harm reduction strategies within Kenya. We are a leader in the region, but what I want to say is we still haven't reached our target.
Thank you.
We have a lot more to do.
Thank you. Let's hear from Onesmus.
Thank you, Debarl. I think I also just want to say thank you to the Cabinet Secretary who turned out to be a harm reduction champion yesterday. But what I want to say is there is a growing angle to drug use. Underage and children of women who are using drugs. This is another forgotten lot. A mother who is using drugs, injecting drugs with the child, what is the child absorbing at that growing stage? Yes. This is the area I think we should actually now start to push our focus onto.
Thank you. Thank you very much.